are in listen-only mode.
Good evening, everyone, and welcome to tonight's webinar on problem solving with 3D sonography of the uterus and adnexa, presented by Dr. Rochelle Andreotti. After tonight's presentation, participants should be able to understand the use of 3D reconstructions in the pelvis to assess uterine shape anomalies, IUDs, endometrial abnormalities, and fallopian tubes. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this educational activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Andreotti has no disclosures. Disclosures for AIUM staff members and individuals involved with planning this activity were provided in the email you received. During tonight's presentation, if you have questions for the presenter, you may submit them by typing them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Rochelle Andreotti.
So in the next 45 minutes, let's have some fun with a series of patient cases demonstrating problem-solving techniques using 3D ultrasound of the uterus and adnexa. So as an artist has carved a work of art from a dead tree in this park in Bordeaux, France, we are going to slice through 3D volumes to obtain our work of art, a final product that answers a clinical question. So when we do problem solving in the pelvis, we're usually talking about the reconstructed coronal plane. And the coronal plane of the uterus and adnexa usually cannot be visualized using traditional 2D imaging. But it answers important questions that can't be previously addressed with the traditional 2D imaging. And the majority of these applications involve the uterus. As we can see here, a nice coronal view of the mid-section of the uterus. So the goals of this presentation are to show examples that illustrate practical applications of 3D sonography of the pelvis, in assessing uterine shape anomalies, improving the visualization of the entire IUD, delineating and locating abnormalities associated with the endometrium, and reconstructing the fallopian tube when adjacent cystic structures are demonstrated. So how do we do these manipulations to obtain our 3D reconstruction? First, we do a manual or automated sweep, which is performed to obtain a volume, and we do this sweep through the apposition plane, that's usually the sagittal plane of the uterus. Then a multiplanar format or display will just appear, and these are 3 orthogonal planes with or without a surface rendered image. And the surface rendered image is a thicker slice image through the volume with depth perception that's improved by different computer-generated shading and lighting effects. Then we're going to slice and rotate using a marker dot or line to select our scan plane from the volume. So here we see our multiplanar display, and as we can see here, our acquisition plane, the sagittal plane. Then this green line represents our second plane, which is the transverse plane. And then the blue line, our coronal plane. And then the fourth quadrant would be our surface rendered image. So we perform this type of technique using a method that was first described by Dr. Alfred Abu Hamid in his article that was published in JUM in 2006. So what was suggested was that we first place the crosshairs here at the mid-level of the endometrial stripe in the sagittal plane, and then rotate the uterus in what we call the Z plane, clockwise, counterclockwise, so that the long axis of this endometrial stripe is along the horizontal axis, as we can see here, in this sagittal plane. Then we move to our second frame, our transverse plane, where we do the same thing, place our crosshairs at the mid-level of the endometrial stripe, and then rotate using the Z rotation to align this endometrial stripe with the horizontal axis. And then we move to our third frame, which then is our mid-coronal plane. And this, then we could also show the same plane as a surface rendered image. We can then take this plane and we rotate it using the Z rotation so that the fundus of the uterus is on top, which is the traditional orientation that we're used to seeing. Okay, so now moving on, let's just talk about uterine shape anomalies. So why is this important? Uterine anomalies are associated with an increased risk of infertility and obstetrical complications. So the correct diagnosis helps us to minimize these complications and manage infertility. And the need for intervention and the type of intervention is often determined by the proper classification of the anomaly. So these anomalies, occur in about 3 to 4% of all women, but they're a lot more common in women with problems, such as 7% of infertile women, and then 5 to 10% of women with recurrent early miscarriage, and up to 25% of women with late miscarriage or preterm delivery. And these miscarriage rates will, of course, vary with the type of anomaly. So when we classify these uterine malformations, in the United States, most people at this time use the classification according to the American Fertility Society. And this was first established in 1988 and is very widely accepted. The classification is based on the extent of failure of normal development of the uterus, and it groups anomalies with similar clinical manifestations and treatment together with the prognosis for the pregnancy outcome. So here is our classification system according to the American Fertility Society. And as we can see here, the coronal plane is the plane that they show us to demonstrate these anomalies because it best delineates the anomaly. And most anomalies that we do come across are going to be in either the septate arcuate type of anomaly, with the arcuate being the mildest form of the septate uterus, or there'll be fusion anomalies, which include the bicornuate and didelphys uterus. So one of the most useful applications in anomaly evaluation is to determine the etiology for two cavities seen by 2D imaging. And here we can see 3 different examples of 2 cavities seen in the transverse plane, and each represents a different anomaly with different management for each one. So our first is a 24-year-old gravida-4 para 004 with recurrent pregnancy loss at 11 to 15 weeks gestation. So we do our 3D reconstruction, obtain our coronal plane, and we find that this is a sub-septate uterus. Okay, so a sub-septate uterus is a result of lack of resorption of the uterine septum after complete fusion of the Mullerian ducts. It may be partial or complete. In this case, it's partial. We don't see the septum going all the way through the endometrial cavity into the cervix. We see a smooth fundal contour up here, and it's associated with early pregnancy loss. But management of infertility with this particular anomaly includes a hysteroscopic metroplasty, a surgical procedure. And here's just another example of a complete septate uterus. So here we can see the septum going all the way through the endometrial cavity into the cervix. So our next patient, a 27-year-old gravida 1 para 1 with a history of a spontaneous vaginal delivery at 34 weeks gestational age. So we can see our transverse view again showing the two cavities. And in this patient, when we do the 3D reconstruction, we can see that we have two complete uterine horns. This is a uterus didelphys with two complete cervices. So this is a complete duplication anomaly, an AFS Class III, where we have lack of Mullerian duct fusion forming two separate uterine horns, two endometrial cavities, and two cervices. This may also be accompanied by two hemivaginas separated by a longitudinal or transverse septum. It's associated with miscarriage and premature delivery, but this is not amenable to surgical management, so we really want to differentiate this fusion anomaly from the septate anomaly. And here is our third example of two cavities, a 25-year-old gravida 0 with an incidental finding on a pelvic ultrasound performed for abnormal bleeding. So we do our 3D reconstruction here, and we find that this is just a small septum, an arcuate uterus. So this is the mildest form of a septate uterus with a minimal septum of less than 10 millimeters indenting the uterine fundus, so we can see here. It's commonly considered a normal variant. No intervention is necessary, but there are some reports of increased second trimester loss in preterm labor. So just an example of how we determine or differentiate between a true septate uterus and an arcuate uterus. What we can do is measure the septum. We draw a horizontal across the top of the cavities, right here, and then we drop a vertical to the top of the septum, and we measure this vertical line. So of course here this is obviously a septate uterus, but here this is a very small septum, and this would be considered an arcuate uterus. Our next patient we have is a 32-year-old gravida 2 para 2 with a history of premature delivery at 28 and 32 weeks. And we can see here it's obvious that we have two separate uterine horns even on the transverse view. And here's a cine clip showing the two uterine horns. But are these widely placed horns a uterus didelphys, or is this a bicornuate uterus? Do the uterine horns actually join above the cervix? Okay, we do our 3D reconstruction here, and we can see that these widely placed horns do converge above the cervix, so this is a bicornuate uterus. And this consists of two uterine horns with two endometrial cavities, like I said, that join above the internal os of the cervix. In this type of patient, there are no associated vaginal anomalies, so that this would be a reason why we would want to differentiate a bicornuate uterus from a uterus didelphys to know whether we need to be suspicious of any vaginal problems. So in this type of patient, no intervention is necessary, but pregnancy is of course managed as high risk. So once again, here is just a comparison of our septate type uterus that has a fairly smooth fundus. But one thing I wanted to mention here is that you can have a little bit of an undulation of the fundus with a septate uterus. Usually less than 1 centimeter is still considered, a fairly smooth fundus. And here is our septum, as opposed to two separate uterine horns in this fusion anomaly. So let's move on to another type of anomaly, and this a case illustrates the limitations of a hysterosalpingogram and how 3D ultrasound can help. So this is a 29-year-old gravida 1 para 1 with a history of premature delivery at 29 weeks. And we can see here on this hysterosalpingogram that there's contrast in a single cavity, and we can see the contrast exiting through the fallopian tube here on the right. And what are the possibilities here? Well, this could be a complete septate uterus where we see contrast in one of the cavities. This could be a uterus didelphys where there's contrast in the cavity of one of the uterine horns. Or this could be a unicornuate uterus with just one uterine horn. So this patient has then an ultrasound, and the 2D ultrasound shows here, sagittal, transverse, that there's only one cavity. So since we do have the hysterosalpingogram, we can determine from the 2D ultrasound that this has to be a unicornuate uterus. But if we didn't have the hysterosalpingogram, there really would be no way, based on this 2D ultrasound, that we would suspect a single uterine horn. So we would need to do our 3D reconstruction, which shows us a partial cavity, like half a cavity, and one coronal area. And so this would definitely make our diagnosis of a unicornuate uterus. Another example, fairly normal appearance of a uterus, sagittal and transverse, using 2D imaging, but I'm questioning uterine anomaly. Well, I probably would not be showing you a normal uterus when I'm talking about anomalies. So once again, we do our 3D reconstruction and we find that we have a partial cavity and one coronal area, a unicornuate uterus. So a unicornuate uterus is the result of failure of development or incomplete development of one of two Mullerian tubercles. Or it could be the presence of only one uterine horn or a difference in size of one horn when compared to the other. And one of these horns, if there's two, would be fairly hypoplastic. And this is associated with miscarriage, premature delivery, and even ectopic pregnancy within the hypoplastic horn. Okay, so much for uterine anomalies. Let's move on to IUD malposition. So why is it important to be able to determine where the IUD is? Well, a major cause of pain, it's a major cause of pain and bleeding in patients when there's malposition. And according to an article published by Dr. Benacerraf and her group, the majority of patients with malpositioned IUDs will present with pain or abnormal bleeding. So how do we visualize the IUD? By 2D, we can confirm the position of at least part of the IUD in the uterus. And when it's abnormally located, the 2D images may show that part of the IUD is embedded in the myometrium, but usually cannot demonstrate the entire IUD on a single image. But using the 3D coronal views, we can successfully improve the visualization of the entire IUD, showing the entire shaft and the arms on a single image. So here we have an example of a 46-year-old gravida 0 presenting with right lower quadrant pain. And this patient had an ultrasound study 6 months ago, just 2D also, which was reported as satisfactory IUD location. But the patient still had a considerable amount of pain, so the ultrasound was repeated. This is a repeat ultrasound. We can see the shaft of the IUD looks pretty good within the cavity of the uterus. And then, if you believe me that this is the fundal portion of the uterus, the arms of the IUD seem to be in fairly decent position. But then we do our 3D reconstruction. And we can see in this nice coronal surface rendered image that the right arm of the IUD is actually pretty well embedded within the myometrium, which in no way did we suspect on our 2D images. So here's another patient, a 26-year-old gravida 1 para 1 presenting to pain clinic. And we see at least a portion of the IUD within the endometrial cavity here, and there's some sort of divot here, kind of in the myometrium anteriorly. So what's going on here? We do our 3D reconstruction, our multiplanar display, and then here is our 3D reconstruction using the thin slice coronal image. And we see here that the arms seem to be located fairly inferiorly within the cavity. I'm going to show you, well, here using these arrows, you can see where the arms are. And then on the surface rendered images, where we can see a little bit better this entire IUD, we can easily see that the shaft is above the arms, and the arms appear embedded within the lateral myometrium bilaterally, and the IUD is upside down. So this actually shows very nicely something that was not well appreciated on our 2D image. So here's another patient, a 29-year-old gravida 1 para 0 presenting with pelvic pain. Once again, We see at least portion of the IUD within the endometrial cavity on this sagittal view. We do our 3D reconstruction, our multiplanar display, and the IUD kind of looks like it has some sort of funny position up here in the fundus. And here when we rotate the uterus around, we get our surface rendered image. Let's enlarge that a bit. And we can see that what we're actually seeing in the cavity was not the shaft of the IUD, but the arms. And the shaft of the IUD is actually projecting out the right coronal area. This is definitely, once again, something we would never have suspected on 2D imaging. So let's move on now to intracavitary abnormalities. First, let's talk about Synechiae adhesions. And here is a 44-year-old female who is status post a rollerball endometrial ablation and a bilateral tubal ligation. And she's now presenting with dysmenorrhea. And on the 2D sagittal and transverse images, we can see a fluid collection up in the fundal cavity. Here's another patient, a 34-year-old female, similar problems, status post a thermal endometrial ablation, presenting with right lower quadrant pain. And once again, we have our sagittal and transverse images in 2D, and we see actually in this patient 2 fluid collections within the fundal cavity. So okay, let's look at our 3D reconstructions. But first, let's ask the question, where are these fluid collections and why are they there? So we do our 3D reconstructions. Here's our first patient, fluid collection out here. Our second patient, these 2 fluid collections, here and here. So let's take our first patient first. Maybe you know the diagnosis by seeing the coronal view now. And on our first patient, we see that we have a left coronal hydrosalpinges. Our second patient, we see we have bilateral coronal hydrosalpinges, but also, what are these little echogenic things here and here? These are what we call Adiana devices. And these are tubal contraceptive devices, similar to Escher coils, but Adiana devices are actually no longer approved for use, so we don't see them very often, but you still may come across them in patients who had these placed previously. So what the diagnosis here, I'm sure many of you already know, is what we call post-ablation tubal sterilization syndrome. These are patients who have had an endometrial ablation and they have some sort of tubal obstruction, usually due to a bilateral tubal ligation or tubal occlusion devices. And because the majority of the endometrial cavity, the main cavity, is adherent, the blood, there still, though, can be endometrial tissue in the coronal area that may bleed. And so there's no way the blood can be released through the main cavity, out through the cervix, and then because there's tubal obstruction, the blood can't go out through the fallopian tube, so it distends this remaining proximal tubal segment, causing severe unilateral or bilateral pain. And this was first described by Townsend and his group back in 1993. So let's move on to another type of adhesion. A 32-year-old gravida 1, para 1, presenting with infertility. And we can see here a very nice sagittal view of the uterus showing a beautiful proliferative type endometrium. But in this patient with infertility, since we do 3D reconstructions of the uterus on most patients who come to our department, we found that this patient actually had adhesive bands crossing the cavity, that there was no way that we could appreciate these on the 2D image. And this very well may be the cause of her infertility. Here's another patient, 35-year-old, gravida 1, para 1, presenting with infertility. And in this patient, we see the sagittal view. We see a thickened endometrium here, and then we kind of lose it here. But, you know, what's going on? I mean, where is the endometrium at this point? So we do our 3D reconstruction, and we can obviously see on the 3D image, the coronal image, that the cavity is very narrowed here. There are adhesions, and this, once again, may be the cause of the patient's infertility. So what do we know about Synechiae? They're well delineated on the coronal plane, but often missed on 2D imaging. But we may suspect them when focal bands or narrowing within the endometrial cavity is seen on the 2D imaging. And also, the coronal view may better characterize complications of adhesions, such as patients with who have had endometrial ablations and may have the post-ablation tubal sterilization syndrome. So let's now move on to other types of intracavitary abnormalities, polyps and fibroids. This is a 37-year-old, gravida 2, para 2, presenting with dysmenorrhea and abnormal menses. And I'll just show you this cine clip. And we can see here the endometrial echo, and on the still image, actually fairly thin, really looks pretty normal. But this patient is having abnormal bleeding. So why is she having abnormal bleeding? So we do our 3D reconstruction, and what we can see that was not at all evident on the 2D images is an echogenic structure here within the endometrial cavity, an endometrial polyp. And of course, we all know that polyps can be the source of some abnormal bleeding, usually intermenstrual spotting. Next, we have a 55-year-old gravida 2, para 2 with postmenopausal bleeding. And we can see here on the 2D images that she has a globular endometrial echo. And of course, because the endometrium appears very thickened, an endometrial biopsy was done, but it showed benign pathology. This patient then also had color Doppler evaluation, and we can see that there is a vessel within the endometrial echo. So we do have a high suspicion that there's a polyp there using the color Doppler, but using 3D, as we can see here, we can actually better delineate the shape, origin, and extent of involvement of this polyp that we really could not appreciate as well on 2D images. So a hysteroscopic polypectomy was then performed. Another patient, a 33-year-old gravida 0, presenting with abnormal uterine bleeding. And we can see on this 2D image that we have a very thickened, somewhat nodular-looking endometrial echo. So when we suspect some type of intracavitary mass, we like to do saline sonohysterography to actually better evaluate the endometrial cavity. So we instill saline into the endometrial cavity through a catheter so we can determine if there is a mass, or better see the mass since it will be surrounded by fluid. So here we do our 2D sonohysterogram, and we can see fluid within the endometrial cavity. But in this patient, we were really unable to distend the cavity very well with fluid. But we can see with the little fluid that we do have in 2D that it looks like there's at least one mass here, and maybe some more, although it's tough to determine whether this is just thickened endometrium. But by doing our 3D reconstruction, even with not that much fluid within the endometrial cavity, we can see, actually panning through the endometrial cavity in the coronal view here and here, that there are too numerous to count polyps within this cavity, numerous masses. So let's talk a little about endometrial polyps. These are rarely malignant, but are associated with abnormal bleeding and cramping. Polyps are seen as echogenic masses within the endometrial cavity, and they're best demonstrated with the contrasting proliferative endometrium that, of course, is more hypoechoic. And frequently, the location, extent of involvement, and number identified are more accurately seen on the coronal view, as we just saw. So often, what's very interesting about polyps is they often cannot be diagnosed by curettage. they're very difficult to scrape off or even scrape a little piece of it off. So that if we see a thickened endometrium or endometrial echo and the pathology by biopsy shows insufficient tissue, then we actually should be very highly suspicious that this is an endometrial polyp and perhaps do a sonohysterogram to actually prove it. So let's move on to this next patient now, a 30-year-old, gravida 3, para 003, with a history of menorrhagia and multiple pregnancy losses. And we can see here multiple masses within this uterus, multiple fibroids, but the one that we're most concerned about is this one here, and this is the same one here. That seems to be associated with the endometrial echo, right here and here. Okay, so we do our 2D sonohysterogram, and we can see that this mass seems to be partially within the coronal region of the endometrial cavity. So then we perform our 3D reconstruction, and we can see a lot clearer the extent of involvement of this fibroid within the endometrial cavity, within the coronal area. And here we can see hysteroscopically the appearance of this fibroid. So let's move on to this next patient. Once again, a patient that looks like there's a fibroid that's associated with the endometrial cavity. The endometrial cavity appears sort of splayed around it. So we pretty much know that at least part of this fibroid appears to be within the cavity. We do our 3D reconstruction, this time even without saline, and we can see the cavity completely surrounds this fibroid. So this is a completely submucosal fibroid, which we could not delineate nearly as well on the 2D images. So when we manage submucosal fibroids, what is the role of 3D reconstructions? Well, the options for management depend on the patient's symptoms, which usually are menorrhagia, fibroid location, as well as the desire for future pregnancy. So if a patient desires fertility preservation and there's a submucosal location, this is best treated by myomectomy. And the location in the cavity and the extent of intracavity extension is critical since it will help determine the likelihood of a hysteroscopic resection. So 3D then can help us determine the type of myomectomy. So surgical intervention is more difficult as the myometrial component increases, and this is a classic Netter drawing showing fibroids with different types of extension or non-extension into the endometrial cavity. So there are classification systems for submucosal fibroids that help us determine what type of myomectomy can be performed. The one that's most commonly used is the European Society for Gynecological Endoscopy, which is a very simple classification classification system that divides the fibroids into T0, a pedunculated submucosal leiomyoma without intramural extension, a T1 type, a sessile leiomyoma with intracavitary component greater than 50%, and these two, of course, would be amenable to a hysteroscopic resection, as opposed to the T2, which is the sessile leiomyoma with an intracavitary component that's less than 50%, which would not be as amenable to a hysteroscopic resection. Okay, but there's also a newer classification system called the STEP W, which takes into consideration other factors as far as size, topography of the fibroid, the extension of the base, as well as penetration into the cavity. And then also it takes into consideration which wall the fibroid's on. So the type of fibroid that would be least amenable to a hysteroscopic resection would be one that's quite large, greater than 5 centimeters, in the upper cavity, as far as topography, has a large extension of the base into the myometrium, and penetration into the myometrium would be greater than 50%, as well as the lateral, if it's on the lateral wall, apparently also it scores higher. So, so here is the scoring system, and let's go ahead and see an example of how we would score a fibroid using actually a 3D reconstruction in the coronal plane. So here we have an example of a fibroid that's partially submucosal, and what we're seeing is that this fibroid is less than 2 centimeters. You'll have to take my word for it. It measured less than 2 centimeters. It is low in the cavity, so far we don't give it any points, but the extension of the base is quite wide as far as in the myometrium. So we give it 2 points for that. There is a less than 50% penetration into the myometrium. Most of this fibroid is within the endometrial cavity, so that's 1 point. And then it is on the lateral wall, so we have to give it a point for that. So this fibroid gets 4 points as far as a scoring system, which would be a low complexity hysteroscopic myomectomy, and so it would be amenable to the hysteroscopic resection. So then one other thing I just want to cover is why a 3D sonohysterogram has advantages over 2D sonohysterography. So first, the fast imaging acquisition of data would decrease the amount of time the patient is undergoing discomfort. Well, that would be a plus. Then we can use the acquired volume and retrospectively reconstruct images in any plane. And thirdly, it has better sensitivity. When we use 3D, it shows a more accurate location and better delineation of intracavitary abnormalities with or without saline, although it has been found in some studies that saline may give additional information due to enhanced contrast. So let's move on to another topic. Here is a 27-year-old Gravida 1 Para 1 presenting for early pregnancy evaluation. And once again, we see a transverse image. And this transverse image shows us the endometrial cavity and then a gestational sac that is separate from the endometrial cavity. And what I want to point out here is that there are 3 different types of pregnancies that can have this appearance in the transverse plane. And these are examples of the transverse images of these 3 different types of pregnancies. And basically, 3D and the coronal plane can help us differentiate between these. And this was very nicely demonstrated in an article by Tanaka back in 2014. And these 3 different types of pregnancies are the interstitial ectopic pregnancy, and here's a 3D coronal view of the interstitial ectopic, the angular pregnancy, which is an eccentric intrauterine pregnancy, but it's still within the endometrial cavity, as we can see in this patient here. And then the coronal pregnancy, which often the terminology is confused with interstitial ectopic, but a coronal pregnancy, the true definition is, it is an intrauterine pregnancy within a uterine anomaly, either within a hypoplastic horn of a unicornuate uterus, a horn of a didelphys or bicornuate uterus, or within a cavity of a septate uterus. Okay, so how do we differentiate these? Well, first, let's just look quickly at the diagnostic criteria that we have seen demonstrated by in the literature by Dr. Timur that he published back in 1992. And basically what we should be looking for is an empty uterine cavity, and basically all of these 3 types of pregnancies have that, at least, you know, so that really can't help us completely. Then a chorionic sac separated by at least 1 centimeter from the lateral edge of the internal uterine cavity. So this may be something helpful, and often what we've heard about is the interstitial line sign, which is the actual coronal cavity, which looks like a line that comes from the main cavity and then intersects with the interstitial ectopic pregnancy at 90 degrees. And then we want to see a thin myometrial layer surrounding the chorionic sac. Okay, so let's take the patient that I first described to you in the for this particular case. Here we have the one endometrial cavity, the gestational sac, and this actually is a true coronal pregnancy as opposed to this transverse view, which is our interstitial ectopic pregnancy. And I'm going to prove it to you with the 3D images. So here we have our first patient. We have two endometrial cavities in the coronal view, and with the gestation within one of the endometrial cavities, as opposed to this interstitial ectopic pregnancy. And the next patient is this patient that actually has an angular pregnancy. But here we can see that the gestational sac may or may not be actually joined with the cavity. It's really hard to tell on this transverse view. And once again, we have our transverse view of the interstitial ectopic. So let's do our 3D reconstruction of the angular pregnancy, and we can see very clearly in the coronal view that this is a lot different than the interstitial pregnancy. We see that this pregnancy is actually distending the cavity, but it is within the coronal portion of the cavity. It is not in the interstitial portion of the fallopian tube. Okay, so one last topic. The adnexa, and of course I don't think we can use our 3D quite as much in the adnexa, but this is one way where we actually can use 3D reconstructions. So this is a postmenopausal female presenting for follow-up of asymptomatic left adnexal cysts. So in the left adnexa we can see this septated cystic structure, and when we see something like this, we often assume that they're just ovarian or adnexal cysts. But if we take our horizontal line representing the coronal view of this structure, and we pan through this sagittal image of this cystic structure, we may come upon a slice that may look very much like a tubular structure, a fallopian tube. And here we have the surface rendered image that corresponds to it. So we may also then obtain an inversion mode. And the inversion mode produces an echogenic cast of this cystic area, which can be helpful then in confirming the configuration of the tube. As you can see here, very nicely confirms the configuration. So if we suspect at all that a cystic structure in the adnexa may be a fallopian tube, we should try at least to do a reconstruction and see if we can obtain a tubular structure to save this patient a cervical intervention. So finally, one more patient, a 42-year-old gravida 1 para 1 presenting with left lower quadrant pain and also presenting for follow-up of left adnexal cysts. So here we see this, once again, a septated cystic structure in sagittal and transverse views. And we try to obtain a 3D reconstruction of this, and we're still getting some sort of cystic structure. So the coronal plane here does not demonstrate a fallopian tube, but I was kind of suspicious, and so I just went back to our initial image and sliced through this image, and lo and behold, I came up with this. I mean, and this looks really tubular to me. You even see a fimbriated end. So this basically proved to me that if you are suspicious of a fallopian tube, even if you don't obtain a tubular structure by manipulating the initial cystic structure in the coronal plane, you shouldn't limit yourself to that, but you should slice through maybe other planes to see if a tubular structure can be found. And you very well may find something like this. So here also we have our or an inverse mode that also shows the tubular structure. So finally, some key points regarding problem solving with 3D ultrasound. First of all, this is the modality of choice in uterine shape anomaly assessment, and there's no need for MRI. It can be used with or without saline sonohysterography to better delineate and locate abnormalities associated with the endometrium. It improves visualization of the entire IUD, and it can help differentiate a coronal or angular pregnancy from an interstitial ectopic pregnancy, and also can be used to reconstruct the fallopian tube when adjacent septate cystic structures are demonstrated. So this is the end of my presentation, and I thank you for participating in this webinar, and I will see if we have any questions. Okay, it looks like we do have a couple of questions. So our first question, why does an IUD sometimes look hypoechoic instead of hyperechoic on coronal reconstructed views? Well, basically it looks hypoechoic because you're not actually imaging the IUD itself, but the shadow of the IUD. So your slice is actually posterior to it. And that's why it looks hypoechoic. If you actually slice directly through the IUD, it will be echogenic. Let's look at our next question. Next question is, what 3D technology or package was used? We use Philips. And often I reconstruct offline on QStation. Let's see. See, any role to 3D ultrasound in the diagnosis of adenomyosis? Yes, I actually didn't bring any cases of adenomyosis to this particular presentation, but that's actually kind of an exciting area, because now that we do 3D reconstructions and see the endometrial cavity in the coronal view, we can actually see the junctional zone surrounding the endometrium very well. Previously on 2D, we weren't able to see the junctional zone very well, and this is, we could only see it using an MRI. So what we can do now is, if there's any disruption of the junctional zone, usually with echogenic material invading it, we can actually, this echogenic material actually represents the glandular tissue that is invading the myometrium, and often, you can really see a lot of distortion of the actual endometrium in the coronal view using the 3D reconstruction. Okay, and see, one more question. What is inversion mode technically? Well, it's just using the reverse sort of coloring of whatever you're looking at. So you're switching from dark to light or light to dark, and that's why it just shows up, instead of being black, the fluid would then show up as the color, or white, if you're using a type of manipulation that just uses black and white. Okay, so I think that's all the questions we have. Oh, wait a minute. Oh, I didn't see it. We do have some more. Let's see. Here's a question. Is there abdominal 3D mode? Yeah, you can use actually reconstructions using any type of body part that we scan. But right now, I think I've found more uses for using it in the uterus than other types of organ systems. And somebody now is asking about giving more details on the Z technique in the Adnexa. Basically, you would do the same thing as you would do with the uterus, just lining up your horizontal with your cystic structure, but it's not really the exact same technique as the uterus. You basically will, once you line up the horizontal with the cystic structure, usually what happens is that the tube will just appear in that third plane as you pan in and out of the cystic structure. If you are going to get a tubular structure, and like I mentioned, sometimes the tubular structure may be in the initial acquisition plane. It's just, and you might have to actually slice through that instead. This is a matter of, you have to play with these images and just get a feel for the different techniques for manipulating these volumes. Here's another question. How small do you make your box to best visualize an IUD? I'm not really sure what they mean by box. I mean, if somebody wanted to type in a little bit more about exactly what you mean. Well, anyway, I think that's about it. And once again, thank you very much for attending this webinar, and have a great evening, and come back and listen to more webinars.
Wonderful. Thank you so much, Dr. Andreotti, and our thanks to all of you who participated in tonight's webinar. Everyone, please remember to complete the post-test and the activity evaluation, and we hope you will join us for future webinars. Good night, everyone. Have a great evening.